All right, today we're going to peek behind the curtain and see something pretty amazing. How doctors use sound waves, of all things, to look inside our bodies and fix problems in our tendons and joints. Let's get into it.
So think about this for a second. How do they do that? How do they guide a needle to the exact right spot deep inside your hip or shoulder without any guesswork? Well, it's not magic, but it's this incredible mix of high-tech gear and some serious human skill. And as we're about to find out, sometimes the technology itself is the biggest hurdle.
So the tool they often reach for is ultrasound. Using sound to get a live action picture of what's going on. It's amazing, it's fast, but it has this one giant, frustrating quirk that can fool even the most seasoned pros.
I love this quote from our source material because it's so real. You can just feel the frustration, right? This isn't just some boring textbook fact. It's a window into the actual debates and headaches that happen in the real world of radiology. And it perfectly sets up the #1 problem with tendon ultrasounds.
Okay, so let's get right to it. The single biggest, most common, and most aggravating issue is something called anisotropy. Believe me, this one little effect causes a world of trouble and can lead to some major misdiagnosis if you're not careful.
So, what the heck is it? Well, imagine a healthy tendon is like a perfectly smooth, shiny silk ribbon. When the ultrasound beam hits it straight on, at a perfect 90-degree angle, that ribbon shines back bright. But what happens if you tilt that ribbon just a little bit? It suddenly looks dark, right? That's exactly what anisotropy is. The tendon hasn't changed, but its appearance has, all because of the angle.
And this shows you the problem perfectly. Look on the left. The beam is hitting the tendon head-on, and it looks bright white, or hyperechoic. That's the healthy look we want to see. Now look at the right. This is the exact same tendon. Nothing has changed except the angle of the ultrasound probe, and bam, it looks dark, or hypoechoic, which is exactly what a tear looks like. A perfectly healthy tendon can literally pretend to be an injured one.
And well, our source says it all right there. This isn't just some small detail. It's a huge challenge that radiologists constantly have to fight against, especially in joints that are all curves and angles, like the shoulder. You have to constantly adjust to make sure you're not being fooled.
So, once a radiologist knows how to avoid the anisotropy trap, what are they actually hunting for? What do the real signs of trouble look like?
They're on the lookout for a few key things. A real tear would be a dark spot that stays dark no matter what angle you look at it from. They're also looking for extra fluid hanging around the tendon, which is a condition called tenosynovitis. Or they might spot calcific tendonitis, these little hard calcium deposits that show up and cast a shadow on the image, kind of like a gallstone would.
Let's make this super clear with a classic case that every radiologist knows, and frankly, a lot of us have probably felt. Plantar fasciitis, that awful heel pain.
When it comes to plantar fasciitis, there is one magic number they're looking for. The absolute key is seeing if the plantar fascia, that band of tissue on the bottom of your foot, has gotten thicker. If it measures more than 4 millimeters, that's the diagnosis. It's clean, it's simple, it's measurable.
Okay, so that's the whole seeing part of the job. But what about the doing? Let's switch gears and look at how this imaging is used to actually perform procedures, like those joint injections we talked about, with incredible accuracy. Now, this is a fantastic piece of insider knowledge. When they do one of these injections, you might think the goal is to get the needle right in that tiny space between the bones. But the real target is actually the joint capsule, that tough, fibrous bag that holds the whole joint together. As long as you get the medicine inside that bag, you're golden. It'll get where it needs to go. So how does this actually work? Let's run through the playbook for two of the most common spots for these injections, the hip and the shoulder. For the hip, it is all about precision. First, you find the femoral artery so you know exactly where not to go. Then, you turn the hip inward, which nicely opens up the target area. You guide a special needle straight down until you feel it touch the bone. Then, you inject just a tiny bit of dye to confirm you're in the capsule before you deliver the whole cocktail. It's incredibly systematic. Now, the shoulder is a completely different puzzle. For this one, the patient turns their shoulder outward. You guide the needle until you gently tap the top of the arm bone. And here's the key move. You pull back just 1 millimeter. That's it. The needle tip should fall right into the joint space. A little puff of dye to confirm, and then you're ready to inject. So what are they actually putting in there? Well, here's the cocktail list. Both get some lidocaine for numbing, and a tiny bit of a substance called gadolinium if it's for an MRI scan later. The main difference is just the volume.
The hip is a bigger joint, so it gets a little more of the contrast dye. About 14 cc's total for the hip versus about 12 for the shoulder. But, things in medicine rarely go exactly by the book. The best radiologists are masters at improvising. So what happens when, say, a patient's allergies completely wreck your game plan?
Okay, problem number 1. The plan is to do an MR arthrogram, which needs that gadolinium stuff to make the joint light up on the MRI. But your patient is allergic to it. Now what?
The solution here is actually pretty slick. You just switch the type of scan. Instead of an MRI, you do a CT arthrogram. This uses the other kind of contrast, the iodine-based one you are already using to check your placement. No gadolinium required, problem solved.
All right, but what if we flip it? This is where it gets really, really tough. The patient needs the MR scan, but they're allergic to the CT contrast dye, the very stuff you use with a live X-ray to prove your needle is in the right place. How can you possibly be sure you're in the joint?
This is it. This is the ultimate test. You basically have 2 choices. Option 1, you can give the patient a bunch of steroids and allergy meds beforehand and hope for the best, or there's option 2. As our source so perfectly puts it, you use the force. You trust your knowledge, you trust your hands, you trust your gut, and you place that needle perfectly, without any visual confirmation at all. It's pure skill.
And that really leaves you wondering, doesn't it? We've got all this unbelievable technology that lets us see inside the human body. But at the end of the day, so much of it still comes down to the human element, to experience, to clever problem solving, and to the steady, confident skill of a doctor's own 2 hands.